Good morning or good afternoon, everyone. We're going to give it a minute to let people get logged in and sign up, who have signed up and join. A bit of housekeeping off the top. We are going to send out the slide deck and materials from this to all who registered, as well as a link to the recording. Also a welcome to those who are viewing not in real time, but really excited for this conversation. Think it's very timely and very happy to kind of highlight some doers, right, in this space of VBC and some of the goings on in the landscapes of safety net care. So if we can advance the slide. I wanted to give a quick kind of highlight, and I'll let my fellow panelists introduce themselves. My name's Carter Kimball. I'm a principal consultant with Health Management Associates. I am based in Austin, Texas, but a vast majority of my work is engaging with states and providers, really, usually public safety net providers in and around the kind of goings on of value-based care, how really to kind of hone in and be strategic and thoughtful about initiatives. Obviously, one of the things that HMA is very active in is supporting those clients and trying to help them be more proactive, but candidly, a lot of it is reactive, right? And so just being able to be smart and aware is really where I spend a lot of time in my day to day. HMA has, broad depth and experience, and on the federal side as well, a lot of experience in CMMI and a lot of their initiatives. And so we do have a very broad view kind of the initiatives that are coming forward and the impacts kind of downstream. Really excited for this conversation. So then I will turn to Lance.
Hey everybody, Lance Donkerbrook. I'm based out of Phoenix, Arizona. I've been in healthcare pretty much my whole career, running the gamut of everything, worked for some payers, provider-based organizations, integrated delivery systems, and healthcare technology. Um, I've been in the ACO world, running a provider-based ACO for the last 13 years, and am now the executive director of the ACO program for P3 Health Partners.
Royal.
Okay, thanks, Cotter. Royal Title. I'm a two-time founder and operator in healthcare. I've spent my career in healthcare, both on the provider side, the payer side, and tech-enabled services, venture-backed companies, mostly focused on helping to build infrastructure to close the gaps between healthcare and community-based organizations to improve outcomes for high needs and underserved populations. I currently serve as the Senior Vice President of Networks at Pair Team, which leads our national partnership strategy across health systems, FQHCs, ACOs, and community organizations. And previously, I was the founder and CEO of two companies, Town Square most recently, and Docent Health prior to that, both of which focused on social and healthcare navigation across community-centered healthcare delivery. So, pleasure to be here.
Perfect. So one of the things as we kind of dive into the content here, there is going to be a question and answer function for participants. Please feel free to either stage questions there. We're going to leave a little time at the end to where we can make sure to get to those. If one's kind of salient to the slide or a particular point that we're on, we can absolutely kind of stop and we'll be monitoring that function as we go. But really wanted to kind of level set from the where is it that the administration is kind of engaged and where are those kind of redesign efforts pointed more broadly? And then as we kind of go, you'll see us get a little bit more tactical and finite as we move through the deck today. Really, this first one is to highlight the fact that CMS is very interested in moving out of the traditional fee-for-service model. That's not a new thought, but the newness of call it a certain pace of change has kind of picked up a little bit. And in that change, you're seeing a lot of kind of promotion or incentives that are driven towards higher accountability for long-term outcomes. Obviously, that reveals itself or lends itself to downside risk and total cost of care models. There's another big push that we've seen through the MAHA movement that is on prevention and chronic disease management, wellness. There is this shift that has also kind of been a long time coming to primary care, really being the kind of coordination layer, and obviously the pressure on that primary care layer to innovate has kind of shown itself, obviously with some technology initiatives, and then also contracting vehicles. How providers engage with the Medicare program is also seeing a kind of evolution that has been a long time coming for a lot of folks that we've kind of seen coming. And I think, candidly, there's always been that interest, but it has been put in a highlight is, where are those levers to bend the cost curve over that long term and trying to design initiatives and contracting against that as a priority. So as we transition into the next slide, it really is the layer down into CMMI, which is the Innovation Center inside CMS. They updated their strategic pillars uh, mid part of last year. And so these are not brand new, but it is the level set for some of the things that I talked about before. Obviously, you see across the top, those pillars of promoting evidence-based prevention, empowering people to achieve health goals, and then driving choice and competition. I think one of the, more interesting pieces that we've seen in this is where is the place for consumers, right, to engage. That's kind of a new lever that I think that the administration's interested in and kind of putting on. And so I would turn to Royal and Lance just quickly on this piece and ask for just kind of thoughts on where you guys have already seen these pillars kind of come into place or where you think there's opportunity within those.
Well, I think one of the things in particular from what we have seen with CMMI and what they're doing is, the team at CMMI is markedly different from, CMS historically. And they're not afraid to get in there and break things, change it, see what works and what doesn't. And if it doesn't, kind of throw it out the window and start over again. So they are moving very quickly. Of course, there's good and bad with that, as there are parts of projects that are not yet fully developed. But, with this specifically, we're going to talk a little bit about that as we get into more detail with our presentation.
Yeah, and I would just add, I think, Lance, to your point, some of the things that are moving quickly and the innovation seems like on the execution level, I think Carter, to your point, a lot of these trends are actually fairly consistent with sort of the direction that CMS has been indicating for a while. It's sort of the pace at which we are pushing on new models and pushing towards the execution of these. And so that's obviously exciting and interesting. But to Lance's point, there's still things that we're going to be working out as an industry as we get into them. But I think this current CMMI administration is very cognizant of the pace of technology innovation as well, and the ability to sort of set the stage for that to come into these operating models.
And I think to that point, some of the kind of transitional or inflection points that we've seen from the transition from the Biden administration to the Trump administration really is, a greater push toward downside. Obviously, I mentioned that before. They kind of removed explicit targets for contracting initiatives, value-based pieces. And there's definitely a much bigger focus on use of technology, which I think is inherent in some of the initiatives that they've seen. We're going to get into a lot of that moving forward. So going to the next slide, I'd really like to kind of let, Lance, as
Sure, sure.
the kind of provider voice, get into how this impacts kind of the operational side of these models.
Yeah, thanks, Carter. I think with that, to start out at even kind of a higher level for a little background in this and what we're doing is that, CMS has a pretty broad-reaching goal of getting everybody into an ACO or a value-based care program of some kind by 2030. And if you look at that, only about 53% are in those types of programs today. So this is just one of 10 new programs created by CMMI in the last 2 quarters, the end of 25 and the first quarter of 26. So there are a lot of different, programs like this looking for ways to get people involved and engaged to kind of redesign that operating model for how it's even doing it. And I think one of the other examples that looking into the LEAD program, which is what we are looking to participate in the ACO world, that basically stands for the long-term enhanced ACO design. That's what LEAD stands for. But something that we've always felt was important was being able to address chronic care management and how we could get that out as an important component. And that's something, to me, the ACCESS program, which stands for Advancing Chronic Care with Effective and Scalable Solutions, is something we really want to try to figure out how we can work into that model. And as the top of the slide says, not really just for Medicare, but also for Medicaid, because there are pilot states in the ACO program where Medicare is looking to bring Medicaid and dual eligibles into the program. So a lot really kind of expands as we try to do that. And in order to make that better, figuring out how we can, redesign the process that we have and go away from really a fee for service model, a pay per click, you do something and you get a payment versus how you can expand that to more longitudinal care, risk-based population management, and doing things along those. So what we're looking at is, in the ACO world, we have downside risk, and we've carried that for I think about 6 years now in our ACO program. So with that, comes greater accountability for being able to take care of that patient, over the life. We've been in this program for 13 years. There are a lot of patients that come and go over any given year, so that's one of the challenges. But we do have patients that have been with us for a very long time. So with that, how do we get into prevention, chronic care management, disease management, and do better things like that? We originally started as a primary care based ACO. We believe the Commonwealth primary care ACO with P3, the foundation is really one of the few truly independent primary care owned, operated, governed, value-based systems out there. So how can we take charge at the primary care level to be able to do that coordination, be the quarterback for the patients? But it's challenging in fee-for-service Medicare because they can go wherever they want. It's not like a managed care program like MA. So how do you do incentives, manage those patients outside of the four walls of your clinic? If you are part of an independent system and it's not a truly integrated system, maybe if you're integrated or you're the only kind of major hospital player or system in your market, you have a little bit more control over that. But like for us in Phoenix, there are a lot of different systems out here. So being able to better manage and direct is something that's a really big challenge for us. So that's something that with the ACCESS program, what are some other trigger points? What are some other benefits we can do to get those patients engaged with us to try to follow along, how we manage, how we coordinate the care. And ultimately, one of the things with the access program is that Medicare CMMI really wants to show that, being able to do this outreach, being able to have a lot of other people involved and engaged is ultimately going to be beneficial and have an ROI for the groups that are doing it and participating in it, and ultimately, saving the system. Um, and as that happens over time, when you get into value-based care, when you get into risk-based care, I don't think it's any secret from what we see with CMS is that they don't really want to expand Medicare Advantage in and of itself. They want to expand value-based care. They want to expand ACO. So I think over time, that lends to a natural convergence of the two. They become more and more alike. And that's something we really want to do from our perspective, whether it be at the ACO or the provider level. Hey, at the end of the day, it shouldn't really matter if your patient is a fee-for-service Medicare member. Are they MA? Are they dual eligible? We want you to be able to perform that same type of level of care. And in the ACO world, with whether it be with access or whether it be with a number of other these programs, that's just kind of the foot in the door. If you have that ACO license, it allows you to bring that redesign in patient care. It allows that flow through to MA, to commercial, to Medicaid, to others. Now, the challenge with that in the meantime, when you're doing all these really good innovative things, many can argue that, well, a certain payer in the market or maybe commercial is benefiting when you don't have the upside. But we really believe it's the best thing to do for patient care, and it will ultimately catch up with you. So at the end of the day, it's not just being able to bend the cost curve for Medicare, but it's for everything. It's being able to provide that consistent level of care, in doing it in a way which will ultimately benefit your patients regardless of the model. Because as you know, I mean, they may be commercial today, they may be aging into Medicare next month. So having all of those consistent and set up is something that's been really important for us to consider, how to look at it, how to do it differently tomorrow from how we're doing it today. Thanks.
Lance, I'm wondering if you can touch real quick. You got there, and I want to pull on a thread that you brought up, which was how hindering is it currently, or how much opportunity is there in the multi-payer or multi-line of business kind of opportunity when a provider or an ACO looks at contracting, or what initiatives kind of deserve resources and allocation, right? As you guys are strategically looking at your market presence or lines of business or patient
Mhm.
mix or however, how much does it matter? Oh, we've got these parts and pieces that are on the Medicare side exclusively that we can't or are disincentivized to recreate in other lines of business. Does that question make sense?
Yeah, and I think, from our perspective, the answer is you got to have a long-term view going into it. It's not a short-term thing, because if even in the ACO world, if you are in MSSP versus lead, you are not getting upfront payments for primary care to support some of these initiatives. If you're not there with a payer yet and a payer's not giving you a care coordination fee, you're kind of investing in the belief in this out of your own pocket, and that's not always easy. But what we have been able to do, in what we're doing now as we look into a contract, whether it's with a new commercial payer, whether we're trying to negotiate a better contract with a Medicare Advantage payer, we're able to say, hey, we're doing this today. And a lot of times payers are looking to Medicare first just to see if it sticks. And if it
Yeah.
sticks, they're sure as heck going to start jumping on that bandwagon.
Yeah. Yeah.
So, the approach that we have is yes, I think the best for everybody to accelerate that would be to have some form of benefit of an upfront investment, or a care coordination fee to help prove that out. But to have, a couple year plan in place with a Medicare Advantage payer, for example, saying, look, we are doing this today. We are already doing it for some of your Medicare Advantage patients where, for example, chronic care management. There are chronic care management codes that certain MA plans pay for, just like
Yep.
fee for service. So there is some carryover. So trying to look for the levers like that are already in place today, saying, look, we're already doing this today. Tomorrow, we want to be able to go at risk at a higher level. And if we are, what do we get in turn for that? Do we get a better MLR? Do we get a care
Yep.
coordination fee? Whatever. So it's unfortunately not, even if you're doing it and doing it at a high level, I think it still is a progression to get there. But I think if you're doing it and doing it well in any program, ACO, with access, with lead, with anything, I think that definitely gives you a foot in the door. Now, something that we'll get into in lead will and with
Mhm.
lead with access, how they fit together, and Royal will talk about is how do you do that? How do you start to
Yeah, yeah.
quantify that? So
Yep.
that's something that we'll be getting into a little more detail.
Yeah, and I like it's almost as if we planned it. Next slide. We you touched on Lance the kind of long view, right? The you've got to make investments into that long view of where your outcomes are headed, and then ideally your plan partners and others are kind of following that lead. I think the point about Medicare being the let's look over there, kind of peek over our shoulder and see how sticky something is a great transition kind of to the look, and would love to hear from Royal on things like access as a model or just the broader view from CMS on that long view of
Yeah.
what are they looking for? Where are the incentives pointed? And then actionably, what does that look like?
Yeah, I mean, I think that long view approach is really important, and it's something at Pair Team that we think a lot about. Um, and just by way of context, I think an important perspective from where I sit, Pair Team is a medical group. We are a tech-enabled provider who's been operating for the last 6, 7 years in California under the Enhanced Care Management Program. And so as you think about sort of like multi-payer, multi-constructs of enabling this type of model, we've been serving patients longitudinally, high risk, high cost. We're the largest enhanced care management provider in the state of California. And for us, the outcomes that we've been able to generate have really been a result of years of building out the care plan and building out upstream capabilities to both address and support social needs, behavioral health needs, chronic disease management. And so as we expand into Medicare, we're now enabling other ACOs, other risk-bearing entities to be sort of AI native organizations to help scale and improve their ability to achieve those value-based care outcomes. Um, and we're thinking very much of Medicare ACOs and particularly the Access Program as a early mechanism to get into AI value-based care contracting. But the long tail of that extends into Medicaid, VBC contracting, Medicare Advantage plans as well. And so we're doing work in fee-for-service Medicare. We're excited about access. I think that's sort of like where the puck is generally going. But it does enable, as we think about the incentives that are being set up sort of longitudinally, um, how do you increase primary care utilization? How do you have more higher engaged longitudinal touch points, supporting and managing chronic diseases, early identification of risks, and then ultimately taking more risk on outcomes-based economics. And so that's a model that we know and we're leaning into, but it is a different operating model than the traditional fee-for-service care management model that ACOs in particular have historically been running. So it does require new technology and new approaches to managing that.
I think that's a great kind of piece to go to the next slide and really on the so if the incentives are there, Lance talked a little bit about those incentives can and do look different based on where you are, what's being offered, the new models that are coming out. There's kind of a new sense of table stakes, right? And able to engage at certain levels. And so I'd love to hear kind of from both of you, how does that look tactically or logistically as you see those incentives kind of present? How should providers kind of engage and look to the opportunity? How should they scope this?
Yeah, Lance, go ahead.
Okay, thanks, Royal. Yeah, so I mean, a couple things looking at that. First of all, from our perspective in lead, today ACO Reach going into the program, we get kind of what I call a hall pass, for expenses in the ACO world. So for the first, this year, next year, going into the program, the costs associated with that with the access model and the service dude are not going to count against us in the ACO. So we have a little bit of leeway as to how we're going to build up on that. So that's good. And but there's a lot kind of in flux with that. Um, in having a model like this, looking with staffing, I mean, can you do more with less? For the care management team, having AI help monitor, measure, report. Um, it depends upon a lot of factors, but the reality in the ACO world, the business is built on kind of the law of diminishing returns. You save money next year, you have a lower benchmark to kind of save money off of the following year. So how do you keep up with that? Um, there's a lot in there in trying to figure out, how to do that with the staff, how to operationalize, how to scale. But I think one of the things that's really important in enabling care management is, even if your care management team has capacity, what if you get two calls into your care manager at the same time? They can only do one. So having ways to supplement that. And then in addition to that, having this enabled infrastructure, it's not hourly, because when somebody has an issue or a crisis or even a question, it doesn't always happen, 9 to 5. So being able to have that, if you're doing that and staffing that with your care management team, it becomes, really difficult to do. So I think there's a lot of benefits to that. And for us, just to kind of wrap up my point, turned over to Royal, is that in historically, our care management team has been focused on reactive, not proactive. And having this type of infrastructure really gives us the ability to look a little bit further down the road and see how we can be more proactive, how we can start to do multiple things at once, even with a static care management team.
Yeah, Lance, and I think been the rate limiting factor in how we've sort of rationed and distributed care management services. Ideally, every patient would have access to a nurse or care manager 24/7, but that's not cost sustainable. And so we create risk segmentations and we allocate resources more on a reactive basis. But now the unit economics have entirely changed. At Pair Team, we have deployed a completely agentic voice care manager, voice and text, who sits as part of the care management team, either on our care management team or on our partners' care management teams, and is able to provide unlimited care management support, infinitely empathetic and patient, and is there, at 10 o'clock at night, if somebody has a need and wants to have a conversation. And we'll have a 40, 60-minute conversation. And during those conversations can pull out new information, identify earlier risks. And so it just allows us to have more of those sort of interstitial touch points with patients, more longitudinal connection, more of an ability to support mid-risk, rising risk patient populations who historically were only engaged after they crossed a threshold. And I think that's really what's getting towards these new models and incentive models. And to Lance's point, we've got 2 years of no MLR impacts. That's going to allow us to iterate on these and prove out the ROI on the access model. And I think it's a really interesting opportunity to innovate and test this out as we get ready for LEAD and other programs.
So I want to do I know I'm going to get to the question. Somebody looked ahead in our slides for sure, because I'm going to fold the question into the next slide. But if we can go to the next one, I think that there is a nice kind of connection here to that kind of scale that we just touched on, both kind of time and resource intensity, but also the scope, right, of a patient population writ large, and how some of those workflows and things like that are able to support intervention or risk identification or some of those different pieces. So I think Roy, I'll start with you on the how does that kind of long view at the population level lead to that kind of intelligence and support the shift, to Lance's
Yeah.
point, from reactive to proactive?
Yeah, this is interesting. Lance and I were actually talking about this the other day. Just like where do you get started in these models and identifying specific populations. And so if we're, as part of Pair Team, working with an ACO and they have a care management infrastructure in place and they're running CCM programs or other programs for high risk, high needs, there's sort of two questions. One is, what can we do to augment the existing team so that we can provide support in between touch points or support off hours, or we can follow up on social needs coordination and get closed loop referral. So some of the things that are just trickier for that team to engage. Um, and then the next question is, where are there populations that aren't being engaged that we know there's opportunities? And that can certainly be mid-risk and rising risk. They haven't sort of crossed that threshold of cost yet, but they're on, multiple medications, multiple chronic conditions. They live in a high social deprivation area. They've missed an annual wellness visit, right? So we know there's early risk factors that we can engage that population proactively. There's also just populations who might be eligible for the care management program or a CCM program, but have opted out because they don't want to pay the copay. Or there's patients who are no longer seeing your PCPs, but are still attributed to you that you want to help provide some support to. So there's these like pockets of value where we can get started and leveraging, a free program in the case of access, where the government is paying for it through CMS. And you're able to sort of deploy care managers at no cost to the patient or the ACO. And that allows us to, and again, that's coming sort of at our risk because we're taking outcomes-based pricing models. Um, so we have to make sure we're really aligned with the PCPs and the ACO. But it does create an opportunity for us to sort of go after net new populations and sort of and extend the type of support we would traditionally provide to patients.
Yeah, I think just to add to that, a couple of things. If you're in an MA or a commercial plan, for example, you get that list every month of who your patients are, where they're at, what they're doing. In fee-for-service Medicare and ACO, you don't get that. It's most of the time retrospective enrollment. They tell you after the quarter, hey, these are the people that were with you for the last quarter. Um, so we're working really hard to get that patient identification and stratification done up front. And the more you can do that, the better that you can become at that longitudinal care. Um, it's really, if you don't know about it and the patient's in and out, you can't really do much about it. And that's the same in the Medicaid world as people come and go. It's more of a challenge to get that consistency there. But the goal with that, we're doing better, as we do that. And the goal is to really get the patients in more for those touch points wherever possible, not just the wellness visit. The wellness visit was something that I think was a great tool and structure to help primary care physicians get paid for something fairly in the fee-for-service world to start to recognize value-based care. But now it's not enough. Now you need to start having more touch points with those patients if they have diabetes or CKD or another condition, getting them in at least quarterly, if not more frequently. So any program like this that gives you an opportunity to have another touch point with a patient, the better you can be in touch with their condition and developing, that longer term plan and keeping them engaged with it.
So one of the things that I mentioned before, that we've got a really perfect kind of segue question that came up in the chat, but I'm going to break it into pieces. One, Lance, is the how are PCPs or providers, ACOs viewing the less infrastructural investment in the social determinants or upstream drivers in the change in the administration? And then to flip it to Royal, you mentioned it already a little bit, but somebody like Pair Team, your view of social interventions or things like that really is still inherently in your model. And so I want you to kind of pull on that thread to say the shift from the infrastructural upfront investment for those initiatives is the same but different view under VBC contracts, right? Under those constructs. So Lance, I want to start with you on a very convoluted
Sure. And
question.
I mean, that was something that we were really, excited about in the REACH program. Um, our team has kind of done everything the hard way. We've got a really good team that really cares about our providers and the patients, and the providers really care about the patients. So when Reach came along, we were really doing a lot of those social determinants things already. And that was one of the reasons why we jumped into that program right away in dealing with social determinants, having the ability to look at interventions for how that affects people's care and working with that. So it's a little bit of a disappointment that that has gone away. The emphasis has been taken away a little bit the last year of the REACH program, and the equity and the access. That's not what the E&A stand for in LEAD. So, but that still is a really important component of how to do that longitudinally because all of those things fit together. So, um, it ultimately is part of kind of that patient care journey and an important factor. So we need to do it anyways. Um, but just like back talking about how can you get a care coordination fee, how can you get this when you are getting a little bit of a benefit or a subsidy or at least a reward in the quality for doing those social things, um, it gives you a little bit better motivation to stay on top of it. But it's something we feel really strongly about needing to do, regardless. So how do you fit that in with everything else and how do you make it work is really the question.
Yeah, and I think that's where Lance, our organizations have had a shared philosophy. Um, Again, Pair Team came from programs that were primarily around very high risk, high needs populations, Medicaid, duals, and we saw the benefit of supporting the upstream drivers of health and engaging in unmet social needs to drive improvements in reducing. We'd see 56% reductions in ED admissions, 21% increase in outpatient visits, 25% reduction in inpatient visits from those programs that we've been running in the Medi-Cal populations. And so for us, particularly as we come into Medicare broadly, whether that's fee for service under and leveraging CHI and PIN codes or working in the access program, and putting fees at risk, we are investing in social care. And I think we're one of the few access providers that is really pretty implicit about that. And that's because we're putting fees at risk, and we've seen the benefits of doing it. And so when we are able to navigate social needs and close the loop on those referrals, like two-thirds of older adults have an unmet social need. Approximately two-thirds of older adults have a chronic condition, and there's real correlations between those stats. And so it's really critical if you're going to be engaging in chronic conditions and you're going to be taking risk-based payments that you're able to address the needs around transportation, housing, food, social isolation, and others.
So, Royal, just to hammer in on that a little bit more, can you talk, and Lance as well, you would definitely have perspectives to this, but effectively the shift from kind of the availability of codes and direct reimbursement for that social care program and the shift in what it tactically means, like how do you organize or operate against a model that really does force it into a risk proposition, right? To be able to say, if you think it's that valuable, put your fees at risk and you can enjoy the spoils of the outcome, right? Like how do you do that both Royal from a vendor in the value proposition development and then Lance from the provider side? How difficult or impossible, candidly, is it to engage at that level?
Uh, yeah, happy to go first. I mean, I think for us, look, we want to be the best partner. We're going to get evaluated based on our ability to help risk-bearing entities succeed in their value-based care contracts. That's our strategy. I think access is a really interesting sort of tip of the spear for this, but at the end of the day, our payments are going to be based on the OAPs and the outcomes aligned payments, and there's going to be a leaderboard for who are the top performing on outcomes. And so we're very much going to market looking for aligned partners, and we're investing in the things that we've been able to prove success in the past, and then increasing AI adoption and technology to bring the cost down and to scale those. So that's our strategy and our approach. But to your point, Carter, it is like this is putting the risk on the providers or on the partners to sort of like put their money where their mouth is.
And that's the challenge for us because if we were an integrated delivery system that owned everything and employed the physicians, and it was a program we really believed in, we could put the edict down that this is what it is and this is what we're doing. The reality is, especially with a group like ours, it's not that easy. They're all, independent providers. The beneficiaries, are fee for service Medicare beneficiaries that have a choice in what they do. And it's a little bit harder to implement at each stage because even if it's something for all the right reasons, doing great things, there is a new code. It's well reimbursed or recognized, the benefit for something else. Change is hard. And when you have a new program, a new code, whatever that's going down the line every year, it just makes it, no matter how good it is, sometimes some things are easier than others to implement and execute upon. And that's always a challenge for something like this.
Royal, you mentioned obviously data and the evaluation piece. As we go to the next slide, talk a little bit about how that data and engagement element is able to kind of empower pair team and partner providers to take a look at predictive capabilities and that kind of population level return, right?
Um, yeah, I think the sort of this tagline on the slide is I think the main point in my mind of just the long-term value isn't about automation efficiency. It's really about how can we increase continuous learning, longitudinal collection of insights. We know for older populations, particularly older populations with chronic diseases or social needs, like their status can change very quickly. And so it's not enough to have an annual wellness visit. The opportunity to connect and build a relationship, not just because you're plugging something in on an app, but you're actually building a relationship and you're speaking to someone and you're understanding what their needs are and you're building trust and reciprocity. You learn so much through those conversations that can help you identify risk factors that you may not have been aware of. And so using that to help have, more tailored interventions, earlier identification of risks, ensuring that they are getting the support they need to get to their primary care doctor, whether that's transportation or just finding the right fit, or they need a virtual provider, or you're helping them to set up medications they're going to get mailed to their home. The sort of barriers to prevention and wellness behavior can come up quickly. And so being able to have those regular touch points with a patient in a really trusted way are critical. And it creates a lot of opportunity for value creation. But again, the challenge has been you have to get the cost model, you have to sort of get that sort of deflationary cost model in place to allow that to be effective. And you have to have an engagement model that is authentic enough and valuable enough from the patient's perspective to want that level of engagement. And so those are like the two dynamics that are starting to rapidly change as we look at that as we look at how AI is enabling these types of agentic care managers, agentic care advocates, to provide that level of support and kind of wrap around the care management team or the primary care team.
But it's obviously a priority of the administration, the amount of, attention they're putting to tech or AI enabled initiatives and trying to put some guidance and structure around that is kind of clear. Moving to the next slide, would love to hear from Lance on how operationally those kind of process and metrics really how do they at what level and how intense are the is the focus from providers on those pieces and being able to really suss out where those investments are returning and where maybe they're
Sure.
missing and need some redirection.
Well, and I mean that's one of the things to look into how to balance that because from our providers, it's patient care first. That's what's important to him. But then, on the business side, I need to remind them that, hey, we do have to have a way to fund this to pay for these things, and there has to be a return on it. And as much as it pains me to say this, quality doesn't always pay the bills. And I say that because my organization in the 13-year history, there were 4 years where we got 100% on our quality score. And in a number of those years, we got $0 in shared savings because of other reasons and other factors. So you've got to be able to do them both. So finding out, which are the metrics that matter that help, can fund the other things that are maybe a little bit more nebulous or you haven't defined as well. And if you look at this here on the potential impact areas, to me, just the very first one, the avoidable hospital utilization is a big one. And if you can make an impact there, you can support almost everything else on this page and have them be, drivers of each other. Um, and because when you get into the others, whether you have the quality, the attribution, the patient condition documentation, those are multipliers. And those can make the impact of what you've done even more important. Um, and for some specifics on that multiplier for quality, it's actually not a multiplier, but really a fraction. And if you only get an 80% on your quality score and you save $1 million, you're only going to get 800 grand. However, if you're able to do a good job with that and you get more patients enrolled in your attribution by the end of the year, now you're looking at maybe 120 patients instead of 100 if you do a good job getting them engaged and involved. And with the correct patient condition and documentation, that's something that has been a struggle for us in the Arizona market in particular, with a lot of the big systems that's what they use as a driver. We as independent providers have focused on the patient care, the patient condition. But at the end of the day, if you don't tell Medicare that you need resources to care for those people, you're doing yourself a disservice. And, when everybody always thinks that their patients are, the sickest relative to anybody else. But if you're telling Medicare a contradicting message that they're actually healthier than everybody else, well, then that's the reality of what happens. So you really need to look at all of these things to me with the increased PCP engagement to make all of those above metrics and things happen. So that's how we look at it.
Royal, given that kind of backdrop of the provider view, talk a little bit about how maybe tech or AI specific enablement kind of gets you to some of those goals or ends.
Yeah, I mean, um, Um, I think one of the areas obviously Lance focused on was avoidable hospitalizations, and so a key part of that is how do you engage people before they feel like they need to go to the hospital, or feel like they need to go to the ED. And so two parts for us. One obviously is the sort of agentic care advocate who can be there 24/7, multiple languages, help to support. But a key part of our model as well has been navigating social needs, understanding the community landscape so we can get them to the right support at the right time. We can help to get transportation to the PCP. So a lot of it is helping not just to remind them of care gaps or remind them of an annual wellness visit, but how do you support them in one, educating them so they understand the value of it, two, supporting the other factors around that might be limiting their ability to access it. And so that takes I mean, it takes it not just engagement, but it does take trust. It takes the ability to want to educate. I think a lot of what we think about is the concept of reciprocity. Like if I can do something for you, you're more likely to do something for me. So if I can help you get set up with a transportation, or I can get you set up on medications delivered to the home, we're more likely to help enable you to find the appropriate site of care or ensure that you're getting back to the primary care doctor. And so that's an earned lever that comes through engagement and trust and providing support. And so really figuring out that upstream engagement side is, I think, one of the more critical ways that we can help. And that drives the primary lever of total cost of care reduction, but it also then increases all the other things. And Lance, I think this is what you're saying, is that helps close care gaps, that helps identify undocumented risks and RAF scores and appropriate HCC coding. Like it all sort of comes out of that as a byproduct, as opposed to I'm just going to run down this diabetic eye exam. So I think that's where the model really becomes interesting and is more sort of holistic in the value creation opportunity.
Yeah, great points and great stuff. So as we kind of close up, next slide, I would encourage participants, if you have questions that we haven't gotten to, please throw those in the Q&A feature. But really just to kind of summarize the direction as we've gotten these insights now, we fully expect that there's, more downside risk to come, that's where, the strategic direction from the administration is looking. There's some acknowledgement to prospective payment, although, again, we've already talked about where those areas for that infrastructural build is really focused. It's definitely more technology than it is health equity or maybe other social kind of drivers. And so reframing the view of how do you get to those things that are still necessary, that you're still able to do. There may be more, tech enablement pathways or particular vendor relationships where you do get to kind of shed or share some of that risk to be able to allow for some of those investments. Obviously, the focus on wellness and prevention and chronic disease management, total cost of care we've touched on, and then AI enablement as well. So I think as we transition into questions, Lance, I'd start with you on if providers or other stakeholders are kind of on the sidelines currently for a myriad of different wholly valid reasons. Where do you start? What do how is it that you look at this and engage, and what are kind of some of the key learnings that you've been able to see through your time with P3?
Well, I think just to start with, I mean, it seems really obvious to me that CMS and CMMI want more people in programs like this. They want providers, not just ACOs, but anybody engaged to start to be able to take that downside risk. Um, Ultimately, they're trying to get at how can they do better for the Medicare program, bending the cost curve, getting better economics. So how do we do that? As an ACO, when these 10 new programs came out, we were kind of overwhelmed, like, oh my gosh, do we have to apply for all of these? And we did have, we do have some capabilities kind of in the area of access, and we looked at it in particular. But then when we started to go through it, it's like, look, not only, can't we do it all, we probably shouldn't. And there are others out there that are probably better suited. So that's when we started working with Royal and others. So how can we find something that is most aligned with what we're already doing and making it easier for each other? They have something that would be harder for us to develop on our own, or maybe we don't. We have a value-based program that really needs to help get this out to others to get better engagement. Um, so that's really, how we look at it. And as we try to prioritize those things over the next couple of years, how can we do things where there are other alternatives? I mean, I even call it, we kind of call it a concierge-like program for us. Medicare is allowing us to do a lot of really cool things now. It's not Medicare Advantage, it's not concierge help, but at the same time, we have to be competitive with those things if we want. So I think it's programs like this that allow us to be a little bit more innovative and to look at things, how can we do something to grow this program, but at the same time be able to be sure that we can manage that downside risk, have other components taken care of. And I think just to kind of wrap it up with access in particular, I could see easily how they could take the scope from just the conditions that they're looking at today to 5, 10, 15, 20 tomorrow or in the next couple of years.
Yeah, definitely. So, Royal, from that same kind of lens, as you have been engaging with providers kind of across the country or in different markets, what's been successful in kind of overcoming that hesitancy or from kind of taking the plunge? Where have you seen like successes and kind of
Yeah.
early wins or kind of phased approaches?
Yeah. I think access has been interesting in terms of laying the like the train tracks for a model that creates this sort of like deflationary pricing tied to outcomes. And so that has made it a lot easier for organizations to sort of lean in, especially with the 2 year gap on any impact to MLR. And then what's interesting about it is like access is not the end. It's just sort of I think a mechanism to help sort of lay out what could be. And so, as we have conversations with Medicare Advantage plans, as we have conversations with Medicaid state directors, like this is a model that we can apply. And this can also cover the base cost for our partnerships. And then we can also contract with you on shared savings around specific opportunities that we want to lean in and we can support that may fall outside of the access program. So it like when you I think when you step back and you look at the bigger picture, access becomes a really interesting catalyst for these types of outcomes-based sort of deflationary AI value-based care contracting models. And if we could use the sort of framework that CMMI has set up with access and how do we apply that to lead in the appropriate way? How do we apply that to Medicare Advantage? How do we apply that to risk-based contracts in Medicaid? At least it gives us sort of a common language. And as an operator, it gives us some commonalities in terms of how do we build infrastructure to do that. So that's where I think it gets really interesting and can start to enable some more rapid scale of these innovative programs.
Very good. I think just to close out, I'd love to get the kind of if for those who are tuning in later or for those who have kind of stuck with us here, Lance and Royal, the like if there's one thing to take away from, the last 60 minutes that people kind of walk away from this with, what would you think is kind of that like here's the North Star, here's the one thing that really people can kind of center and take forward with them as they kind of engage in these things.
I
Let-
think from my perspective, really simply, like we've said a couple different times, uh, CMS, they are trying to find ways to get more people engaged and involved. And it really is about volume. To them, some Dr. Oz has said, many times that it's about volume for these programs, getting people engaged, they want millions of people enrolled in access, not thousands or hundreds of thousands. So, they have some pretty lofty goals and expectations. And it's finding a way to really get it out there so programs like this really become more prolific to everybody. I think that's what I see with it.
Yeah, and I think just to draft off of that, I mean, we heard Dr. Oz say they're going to do a marketing campaign to consumers directly. They want
Yep.
Medicare beneficiaries going to their doctor and asking about their access programs. We'll see how that plays out, but I think the notion behind it is that these programs are coming to the patient population one way or the other. The patients can self-enroll in these programs. It doesn't require a PCP to sign up for the program or an ACO to sign up for a program. And so I think the organizations that are being thoughtful about how to organize around it and decrease some of the, potential fragmentation, I think have an opportunity to lean in. But this is, kind of, where it seems like the puck is going.
Yep.
And CMS is driving more volume, like they're expected to increase. We'll see some iterations along the way as we learn, but yeah, increased outcomes-based payments and deflationary pricing and trying to drive more patients into these full risk programs is what we're preparing for.
Great. Great. Well, I want to thank both of you for providing insights. I think this was really valuable and look forward to future communication. If anybody has any questions or follow-ups, please feel free to reach out to HMA and we can connect to either Lance or Royal. But thank you, gentlemen, today, and hope you have a good rest of your day.
All right. Thanks, everybody.
Thanks,
You
everyone.
bet.